Good afternoon, ladies and gentlemen, dear guests, dear colleagues. Please welcome to the high-level panel, Is Public Health Really Relevant in the New World? Organized within the 6th edition of the European Public Health Week. My name is EUPHA Nagiova. I'm the president of the European Public Health Association, and I have a great pleasure to co-chair or co-moderate this event together with Josep Figueras, director of the European Observatory on Health Systems and Policies, and co-organizer also of this event. As we find ourselves at the brink of a new era characterized by unprecedented health crisis and transformative technological advancements, the importance of public health is more evident than ever. From enduring threats of infectious diseases to the constantly growing burden of NCDs, antimicrobial resistance, climate change, mental health problems, all this within the overstretched and underburdened health systems, the health and well-being of European citizens and European citizens globally is at stake. So is there a way forward? Is public health really relevant in the new world? Let's find together with our exclusive high-level speakers, but also with all of you together. Joseph, may I kindly ask you to guide us through today's event, including the active interaction with audience through the Slido.
Thanks, Iveta. Good afternoon, welcome those here, took the time to walk all the way here. And those online, of course, many people are joining us online. It's really a privilege for us in the Observatory to be under the leadership of EUPHA and give a little bit of a hand to put this first session together. I don't want to moan, you know me, I always start with that. I mean, I really not gonna allow you to moan today. But I will start with mourning, so it's gone out of the way, okay? So we know, we heard, we read that public health is not in its best shape, that public health was not the leader during the pandemic. We realized how all these virologists et al. Were leading the debate much more than public health institutes and professionals. And we're wondering about that we've been writing ourselves in the Observatory and others, what are the causes, why is that, what we can do about that. And we hear always the same thing, loss of authority, underinvestment, fragmentation, what's public health, not enough funding, not enough trained public health, lack of inability of leadership to work with other sectors. Don't be desperate, it's not that bad, but it's pretty bad, okay? So, the first question we're going to put in the Slido now, and actually I realized maybe, so you have to use your own, phones to look at the Slido, I believe, because there's no screen for you in the panel. This is people are already voting. Online. All right. Well, that's not nice because I like to kind of manipulate and lead the vote slightly. Slightly. So the question today is, public health is still relevant in the new world. Of course, we like you to say yes. If you say no, we have a problem, but maybe it is a good problem. What is the most important role that public health needs to play now? Please choose one of the most important responses below. I think it is equal 67. It looks like it's only 1 or 2 people that have voted, actually, but anyway. So the first is strengthening health systems resilience, and we do know that public health plays an important role in terms of the governance, in terms of surveillance, in terms of the communication, in terms of the knowledge transfer, in terms of digital. Play a bigger role in the political economy of decision-making. Actually, I will follow a different list because, of course, the list in your screens changes all the time according to the votes, the way it should be. So the second is harnessing innovation. And we'll hear a bit more from Iveta because innovation and digital is at the core of the next EPH conference in Lisbon. So can we use public innovation and digital to assess risks, to assess behavior, to change behavior through AI? Exercising leadership across sectors, this is the usual one. We need to work on the determinants in other sectors. Some of us, with the leadership of my colleagues here, like Agnès BUZYN et al., we've been talking about not only health in all policies, but health for all policies. It's not just the co-benefits of better environment for health, the co-benefits from a better economy for health, but also the co-benefits in these sectors of better health. Health is good for the economy, Health is good for gender equality. From the health sector, we can decrease the carbon foot impact. So this is another element that may help in strengthening in which public health can play a bigger role. And in that regard, and we just said with Sandra, we're discussing a minute ago, we're worried. We're worried. At all levels, we see less funds for health. Shouldn't public health be that discipline that makes a better case for health? We never had it better. Health for cohesion, you hear that all the time. Health and security. Health and growth, health and sustainability. Now the well-being. Now we're talking that we can measure well-being, that member states should use well-being more than GDP. Don't get me going there. There are ways to measure that. And once we make that case, it's not just the evidence for that case, which we need to collect, but we need to be much better at knowledge transfer, supporting our policymakers, and communicating. Every time I've been asked the lessons of the COVID crisis, there are three: communication, communication, and communication. And public health is meant to be that kind of discipline that can play a key role. 6, play a bigger role in the political economy of decision making. How much public health understands the stakeholders? How much they understand the different groups, the different interests? That take the commercial determinants of health, which was core. We were together in that session, EUPHA, in the last public health conference. How much public health understands the role of the commercial determinants of health? How much works with the policymakers? How much works in the transformation? Dimi Pantelli is leading now a major piece of work in the observatory about transformation. Is public health part of that process, or they stay in the discipline? Of course, we expect some people to say public health is scarcely relevant now, or none of the above. Of course, we are missing many things. Of course, we are steering you in a certain direction, but you are entitled and allowed and encouraged to put any other areas using the Slido. And now, ladies and gentlemen, Charlotte, the chief executive of EUPHA, will tell us the votes say what, Charlotte?
Well, I think everyone is seeing the votes. They're still going. We have 96 people that have been voting. The first one is strengthen health system resilience, and the second one is health in and for all policies. Of course, together with health and all for all policies, it's play a bigger role in political economy and decision making. They're all very linked. I mean, health for finance, finance for health, really interesting. And then the third one, because both of them are equal, is make a compelling case to invest in health. And this is really something we're working, as you may know, EUPHA has sections, and we are working with the economic sections to make cases, but not only a case, not only a study, but an infographic case. So something that we have and we can all share and amplify and show. For instance, €1 invested in health promotion is 14 euros. Économisé, sorry, I lost the name, saved, thank you. And there's not so many things that we can actually invest €1 and save 14. It's really a big case, but we're not making it that much. Then, of course, innovation. Innovation is 19%, but I'm pretty sure EUPHA will have it raise pretty much. And I'd like to share the Q&A, if you'd like, because we really would like for the first round for our speakers to reflect on the Q&A and what EUPHA and Josepa said, but mostly what the public has said.
Yes, EUPHA, actually, I wanted you to come back using this and emphasize those areas that you are particularly leading within EUPHA.
Yes, honestly, I'm a bit surprised and disappointed. Just like Charlotte anticipated, because really I believe in innovation and cross-sectorial collaboration and cross-disciplinary collaboration. So actually I would like to highlight a little bit my vision, my dream about the public health community in the future. I'm not saying that you are wrong, but I just would like to maybe try to convince you why I believe in innovation. So I think with the currently ongoing challenges, we are somehow not very efficient in closing the gap between the cutting-edge health solutions and widespread adoption across the population. So it is somehow not happening. And despite the notable progress in AI, digital systems, precision medicine, genomics, and social innovations, these promising solutions often remained underutilized. And I believe that establishing an ecosystem that encourages collaboration, strategic partnership, and effective scaling of innovation solutions is really needed, is really paramount. So, but to be effective, and we will hear, I'm sure, from Sandra and from other speakers, that being effective and being kind of like competitive with the private sector, we need policy frameworks and governance mechanisms that are essential for the private sector and other non-traditional partners to promote equitable and value-driven innovations in public health within and across the quintuple helix system or framework. That means from academia, government, industry, community, and the wider environment. And as I said, I really believe in cross-disciplinary, cross-sectoral collaboration, and through this, we can leverage the experience, expertise, and resources that the private sector has, accelerate innovation, and improve efficient services and enhance health delivery to address the pressing health problems. So finally, by critically examining these intersections, I'm sure that we can stimulate collaborations and create a platform for sustainable, innovative solutions in public health. This is, sorry, I had to say this.
And very much needed, and a good add to join us in the EPH conference in Lisbon this year, which will be all around these issues. Right, Iveta?
Around innovations, tailing the sales of innovations.
Charlotte, so what are the other points? Because there's 20% vote that said is not included in there, and even a 5% vote that says public health is totally irrelevant.
No.
Yes?
5%?
Yeah, 5%.
None of the above. 5% say none of the above.
Okay, I just put in the wrong place.
And no,
so zero
say it's not relevant.
I feel much better now, thank you.
So this is why I was going to the
only 5% said none of the above, so we got it quite right, Iveta. That's very good news.
Right, but I'm curious. I don't know whether we have time to analyze the answer from the audience, but actually this first round of questions and polls is something what should start the discussion for our esteemed guest, and maybe without further ado, we should already start this. So, Charlotte, can you please show us the final results of the vote and also somehow to show it to our panelists, because I think they will have to react.
The panelists, they don't see it, I think, so they'll have a bit of a problem here.
While you're giving the floor to Sarah and Hans, who can probably see them, I can share that. But it's really the same that we say, bigger role on economy, exercise leadership, but mostly on the Q&A and what the people say, none of the above. They're both talking about methodology and data. How do you have a good methodology? So just not about innovation, but how you do innovation. And also they remind about the problem of equity and social needs. And this is something we are public health. We've got to leave no one behind. And the last thing I've seen on the question is that it has to be people-based, center-based, and it has to come from the people. So let's not invent something without the communities. I think
that's absolutely perfect, and I know that rings the bell to our regional director, no one left behind, and rings the bell as well to all of you, really, to Francesca on the data side, on the politics, on the equity, and so on and so forth. So panelists, the question now is to you. Now we started, as I said, with the what. What is that public health has failed? Do you agree that public health failed? I'm going to start here. I have to say some random order that I've been given. So it's not about hierarchy or leadership or anything. We just have some order that we have in our list in our various questions. So I think, Sandra, starting with you. Sandra, we count on you being challenging. That's the reason, I guess, that my colleagues have thought about you being first. Are you disappointed, Sandra, on the role of public health now? And is it really helping public health in the portfolio of the Commission? Is it really giving you the support you need? I'll ask you later when we say what now, a bit more what do you want public health to do. But at the moment, what's your assessment of these results that you saw at the role of public health? And we ask you to be particularly blunt, so you don't need to be politically correct.
Are you disappointed? Yes. And I will start from a very small piece of evidence. We, as you said, virologists and all took the floor and were speaking and were trying to even be helpful to ministers. And I'm very conscious today that I'm sitting next to a former minister who was completely invested by the whole wave of COVID. And so she will definitely have an idea of what public health meant at that moment. I'm very happy also to have Francesca next to me because, you know, let me say, unfortunately, my answer to your thing, my first answer, was make a compelling case to invest on health. And I feel that after COVID, you got sort of primacy of space because after the virologist became a bit too tedious and we were all bored about their intervals of confidence and all, we turned to the real source of knowledge for health in a community. Because, you know, it's very funny, in Italy, we have an expression which is sanità pubblica, which is not public health. And even if you say salute pubblica, it would not be public health. So all Italians are always wondering, how do we translate public health? Public health is a very clear concept. You need to have the expertise to tell a group of members of government, I think, what they should do to keep a community healthy. Then, you know, to keep this community healthy, you can have different ideas about what to do, prolonging life, keeping them, I would say, healthy without the non-communicable diseases and the chronic diseases that we have. We can have differences there, but a community that is healthy would benefit from a very good group of public health people. Many of my good friends in public health in general come from families that were populated with doctors, and they could not face an operating theater, and they say, I went to public health because it was the closest that allowed me. But what I saw...
Sandra, is that a good way to start public health? Because you don't like to be in operation theater?
No, you told me to be disruptive. So let me say, after the COVID, with all the attention that you got, I was expecting you to stay in the first line. But let me be very clear, this has not happened. So I was left alone, holding a baby about how much money I need. So I go back to my first point. My point is that you need to be the multipliers of those necessities that are not very visible to a single hospital or to, I would say, a single doctor, because public health is a different concept. Is, you know, it's not the sum of all the health of all the people. It's community health. For instance, having chlorine in water is something that is, you know, decided at a certain point as a public health measure. Now, we could have discussions today about this measure, but public health means that for the common weal, for instance, you say it would be better to vaccinate. Now, the real problem is that many of you have encountered the black force of those who somehow felt that the rights of the individuals, were very difficult to defend in a COVID period. We had many disputes about the COVID certificate. We had many disputes about vaccination. I'm going really far just to mention that we felt that the public health people were very useful at that point because they were saying, for the public good, it's not just for you that you vaccinate also for the others. So let me say, this rationale of the public health action is fantastic. It's a multiplier. It's a multiplier because it says certain things, and we go into a much more difficult field, which is prevention. Today there was a big discussion in the Italian press because just today the government is going to finally decide on the sugar tax. This is also something that would go into how you deal with public health and how you prevent certain diseases. So if you have a public health expert that tells you with numbers, with ideas, why it's good for the community, you have an easier time. What I have felt is that at the moment, I the public health experts had the limelight. They were even getting a lot of space. We in OECD had a lot of space for public health topics throughout. But today, I feel that we go back to the previous normal, which I didn't like. And let me say to all of you, it's not just the technicalities of governance, of surveillance that you need to be dealing with, but you need to really advocate a different approach to health, which is a community-based approach. And this, if you don't do it, it's not the health professionals that will do it. It's a different thing. It's a different thing that needs to come from a more philosophical approach to health in a community. If I may, then we will have opportunities to go even further.
Yes.
Let me take you later.
True,
on
when
that,
you say one
Sandra.
health, it's now the glue for everything,
Right.
One health. But you know, I have not had much help in my One Health battle in Geneva on the pandemic agreement, where there is even a few delegations wanting to delete that article because One Health is not interesting. And, you know, by the way, in delegations that have many animals back home. So I wonder, I didn't hear one public health expert coming and helping me and say, no, Europe was right in asking for One Health because, you know, in the future, we will be even more susceptible in communities to have. And I stop here, but I would like to say you had the limelight, you earned the limelight, but then you are recoiling because the force is very strong from those who want to keep their individual lives and for those who don't want to fork out the money, because you need to also say public health comes with a bit of money.
So clearly very positive about what can be done, very positive of what the tasks, but very challenging. In the slide though, Charlotte, we need people to react on that because that's a serious push, a serious provocation to, we'll come back to that in a minute, Charlotte, because we're running a bit late
if
already.
I just may...
I will go back to Sandra later about the specificities of how would you do that, how you have done it indeed yourself.
But I think this is a very important opening because I really like it, Sandra. I think this is what I feel also about the public health community, that if we want to be sustainable in the future and relevant, we have to somehow go back to the potential that we had and learn the new skills. And I'm sure that we will have more capacity and time to develop that in the third round. So we would like to hear from you, what can the public health community do? But this was an excellent start because I think it showed us the mirror, how we are, where we are currently, and where we should head. And I'll give you back.
From the director of DG Santé to the director of the World Health Organization, Hans Kluge, welcomed online to this meeting today. The WHO, the organization, public health organization par excellence. Difficult days, difficult challenges we have on the table, and you yourself played a key role in leadership, Hans. What are your reflections about this, the failures and successes, and what should public health be going now?
Thank you. Do you hear me, Joseph?
Very well.
Okay, excellent. And hello to EUPHA and to my good friends, Sandra and Francesca and Sarah, and so nice to have Agnès also with us. I regret very much I cannot be with physically, but I just returned 2 weeks from Turkey. So on the public health, is it still relevant? You have been hearing me talking previously, I think, about what I call the dual track approach. We live in a kind of a perma crisis. When I inherited this region 4 years ago as region director, this was a pretty peaceful region. But since then, we go from crisis to crisis. So the dual track approach means for countries, for WHO, to be able to manage crisis and prepare better for next one, while at the same time continue to provide essential daily health services, which were interrupted in the big way during the COVID-19. And public health, obviously, is at the basis of both essential public health functions for the crisis, and then on the universal health coverage with the aging population and the shrinking health workforce, their prevention is the key word. What we need to do better, and I think both Yvette and you have hinted at that one, is to explain to the people and communicate. I think we both remember those heroic meetings on public health where people for 2 days would debate about the definition of public health and then go home and we didn't start the normal agenda yet. So we have to be very practical. For me, Public health is a kind of a combination of health and politics. It is the art of the possible. You have to identify what needs to be done, how to do it, and most important, then do it. And for this, you need three things: the political leadership, the technical rigor, and third, the operational excellence. And we have examples. Data is key. We know from our latest survey among children in schools that if you look at 15-year-olds, 1 out of 5 had experience with e-cigarettes. 50% of the 15-year-olds have a recent experience with alcohol. We see what's happening with measles because the immunization was disrupted. 40 times more measles this year than the previous years. So we need to make the case to communicate this. And the basis of public health is surveillance. It means data from the front line, sift those data, analyze those data, and then use it for program performance improvement. But of course, we have a big enemy, a big challenge here. It's the tremendous pressure of people who want unhealthy societies, the commercial terms of health. And that's why I'm very appreciative to Deputy Prime Minister Frank van den Broeke under the Belgian EU presidency, who will launch with me on 12 June our WHO European report on the commercial terms of health. Thank you.
Thank you, Hans. Important points there. Indeed, you added a lot of evidence and ammunition in our main sort of strategies. Very clear, practical. I like the pragmatic side. The need, as Sandra said, to be able to explain to policymakers, and particularly like the mix of health and politics, which brings me to Sarah Cerdas, member of the European Parliament. Sarah, thank you very much for being here online. Politics, politics, and politics. How has public health helped you in the politics, pure politics of being in the European Parliament? And if I may say so, all very worried at this end for the next Parliament and the kinds of politics we'll see in the next Parliament. So public health, if anything else, will have to play a key role there. Sarah, what's your reflections on that? Welcome.
Yeah. Thank you. Thank you very much for having me here and for the invitation. It's always a pleasure to share the panel with such distinguished colleagues. Indeed, the last 5 years I've been working as a member of the European Parliament. Just a side story there was that I'm a medical doctor and I actually decided to go for the public health specialty instead of being a surgeon, because I kind of felt in public health I could have more outcomes in regards to the whole population, not having only a single patient at a time. It has been quite the adventure. And in this parliament, we managed to advance a lot when it comes to public health and better public health. What we have at the moment is that the European Parliament legislates for 455 million people, 27 member states. For instance, laws in Portugal, 70 to 80% of Portuguese laws come from what we decide in the European Parliament as co-legislators. And this is very important. One of the main difficulties I have had during these last 5 years was to have more backup. As Sandra was speaking about the importance of having One Health in a pandemic accord or treaty, or today, I don't know what they're calling it today, and to have that backup. In the parliament, this mandate, we have a few MEPs that were health champions, so we managed to secure important gains for public health. I give an example. For instance, we're going to have cleaner cars by 2035. And also we managed to increase our air quality directive and put it together as a WHO standards. But we lost many other battles that are quite important for citizens and also for the health status of an individual.
Do you feel that the public health has failed you there in these battles?
Yes, I do, because the lobby exists in the EU, is legislated, so there's this transparency. And I can give you an example. For every 30 requests of a meeting I would receive by different entities that they have their own interests. I would only receive one from, I would say in my office, from the good side. So there's this lack of information coming to legislators.
Why the white side, not the white, sorry, why the good side? God
Well,
doesn't
I usually say the
with the
good side
dark
because
side.
me, me and my colleagues working in a health policy, we are medical doctors, and we usually see those that are trying to advance and doing lobby for the good of the health, improving the health of the populations, versus others that are lobbying for their own interests. And we know that health can be staying behind. It was just a name that we put among my own office. But it's quite relevant to say this, especially the gap that we have from us politicians to the academia, to the best evidence. And that was something that I really was shocked when I came to the parliament. For instance, when I was doing my mental health report, we asked for a ban on conversion therapies in the EU. It's already widely banned in many member states, but some are lacking to reach it. And I thought that wouldn't be problematic. That was the most problematic point I had during the negotiation of the mental health report. So something that's a given already in academia, in science, still is not given when we're talking about politicians and also the policy making process. How it's going to be the next mandate, we're going to have more conservative people out there. I hope that there's still a huge push for health, but what I feel is that there's going to be a huge push for diseases, and rightly so. We ended up this mandate with lots of outcomes, but we ended up with the European Beating Cancer Plan. But when then we want to legislate on non-risk factors for cancer, the ambition just drops dramatically. So this is something I felt in this parliament. It's good to talk about health when we're talking about disease and not health per se, and health and well-being. And this is something I hope that the new MEPs will have better support from civil society organizations, such as the ones here present. I can say that you guys always have been working very hard together with me, and for that I truly appreciate it.
Right.
I think, Iveta, we are getting a lot of this, the what now answer that we have in the third block,
yes,
right?
yes. We are getting a lot of answer of what now, because we should tell you that we are having 3 rounds of questions, but we are going to kill the third round because we are already receiving. So first was what, to identify what are the problems. The second, so what, and we will hear more about it, some examples of good practice, but we did not hear the other speakers yet.
Exactly.
But the third one was what to do in the future. So because we are receiving already a lot of answers, this is just to warn you and also our speakers that we will exchange again the list of the panelists to answer our questions. But actually I wanted to jump in for a while to Sarah's comment, because I think it's very relevant also within the context of EUPHA and also the observatory, the knowledge translation. EUPHA is a science-based organization. We have the journal, we have the conference, we are the organization originally of the scientists, and we really look for ways how to collaborate more closely with politicians to help you to create evidence-informed policies. I think this is absolutely relevant. So thank you, Sarah, for these comments. It's very important and relevant within this context.
All the speakers today are giving public health a very clear lesson of how to move, and certainly to fight the dark side, they need you to be there in the parliament. Going from politics to politics, Agnès BUZYN, former Minister of Health in France and former ATG in Doblejo. So an extremely interesting is too poor a word to define your experience. Exciting, fascinating, and knowledgeable experience about health and politics and what you can do then from Doblejo. Now Professor of Haematology. Agnès, what's your view on all that? Where you felt supported when you were in government, fighting at the beginning of the COVID pandemic, tobacco legislation, vaccination legislation? You'll tell us about this experience, like other colleagues will take us later. But how do you feel about public health?
Well, I first would like to come back to my own experience during COVID. You wanted to be disruptive? I'm going to be disruptive.
Please.
I'm not so sure that public health failed, but we don't have to fight against lobby only. We also have to fight against cognitive bias all the time. And to give you a few examples, I was really Minister of Health at the beginning of COVID. I realized very, very early that it was a danger, before even the warning of WHO. Around end of December, I've seen on social media that something was going on in China, and I was really worried. And we opened the crisis center in Paris, the 1st of January. So we were really, really early. But what I've faced is that it was very difficult to translate this fear into public warning. First, when you look at the FAQ, which was done by WHO, it was the 30th of January. If you read the FAQ, there is a cognitive bias. The FAQ says northern countries or rich countries will have to help poor countries. Why? Because all the alerts on pandemic and outbreaks are always about low and middle and low income countries in the south. And so they thought, in a way, or the way they expressed it during the fact, that for northern countries and rich countries, it wouldn't be a problem. So how do you warn your president and the prime minister when nothing is written with the fact, except that it's going to be tough for the south? First bias. Second bias, I try to warn...
How did you answer that from WHO? Because you're ADG as well.
No, I wasn't ADG at that time. I wanted to later, but Hans knows what I feel. The second problem was Europe. We received the first patient in Europe coming from China the 24th of January. It was a French patient, so I called the hospital, tried to get information, and then I realized that all the data we received from China were false. I understood that the data were false. Then I decided to call Stella Kyriakides, the commissioner. I said, we need to meet. And she said, oh, a ministerial meeting is not my competence. So I tried to call all my colleagues, Minister of Health. And they said, oh, it's the flu. And it took me 3 weeks to get a ministerial meeting in Brussels. 3 weeks. It was the 12th of February. Why? Because out of 27 countries, 24 countries didn't feel that there was a danger. So it's wrong to say that we are not prepared. We were preparing for a pandemic for years. We had a lot of ranking of countries. We had the IHR. We had the joint evaluation by WHO of the countries. But obviously, how do you overcome cognitive bias from the public, from governments, even from the Commission at that time? That is not a problem. So I don't think that public health failed. I think we have a problem of fighting against our own bias, but we will speak about that. Yeah.
Behavioral science, cognitive bias is very much at the very core of the political economy. It's at the very core of transformation that happens not only in public health, in any political decision making. Look at the forthcoming parliamentary elections and the kinds of cognitive biases who we see in the views of our voters, our pure democracy. But how did public health help you in France in these cognitive biases? How did the public health profession were there supporting you on the press, in television programs? Were they there?
Well, it's
difficult question.
To be honest, they had so many problems to modelize. That problem, if you want to be to make evidence-based policies, you need data, you need models, and you need arguments to translate it in a public policy. The problem with COVID was special because we had so many information at the beginning on the virus that in fact, they were not very helpful because they didn't know. And when you're a government and all your experts say, we don't know, it's very difficult. But we should explain the population that sometimes we don't know. And
exactly.
This is the issue.
Uncertainty was the key lesson in getting population support and allegiance and following. Show, I don't know. We learned that so many, Angela Merkel and many of Jacinta Ardern and others, those were the best communicators because they were able to say, I don't know. Great lessons from you, Agnès. We'll come back to you. Iveta, in the next section, we'll come back to you with more questions about best practices, right, Iveta?
Yes.
But let me go back before to Francesca, and then you will. Francesca, our partners in crime with the Observatory. We are the servants of the people. We are the ones that provide the evidence, organize the evidence, try to communicate the evidence, bring the evidence in the policy process. So, how was public health for you? Did it help? Did it support? Do you work close with them? Thank you. I always can count on you, Boris. Thank you.
Yes, we work close with them, but maybe we have lost a little bit track of what public health should be. I mean, it's one of the lessons also from COVID-19, and we work together a lot on the issues of resilience and with a lot of focus on health system resilience. But in fact, what we need is the resilience of populations, and making population resilience means addressing those wider root causes of poor health and inequalities like poverty, deprivation, the disadvantage, and so forth. And we have lost a little bit of track. I mean, even in public health, which is very much about equity, about population health, and so forth, but there is a little bit of a biomedical view of the words, which is, biases us a little bit all in some of the fundamental. And that has to do then with the sort of alliances and partnership that needs to be built with the housing sector, with those that deal precisely with the underprivileged populations. Unless we address the root causes of poor health, we're going to be failing, whether it's the next pandemic, whether it's non-communicable diseases and so forth. I mean, we have seen it during COVID-19, the gradients of mortality. It's so, by socioeconomic status or by any gradient, by any indicators that relates to disadvantage is really huge. So for me, we need to get back to those fundamentals.
Oh, wait, you get lots of applauses. You should be very happy from the audience online.
Okay,
That's very nice.
I can't see
like all of you. I can tell you. I see them on my left eye. But why? I mean, we know that. But why are we not getting there? You are in OECD, working with all these other sectors, housing, economy, and so on.
Because
what are we doing wrong?
I think sometimes we're, I would not say presumptions, but maybe I'll do something that a lot of you will disagree with, but we say health in all policies. If you go to the housing sector, if you go to education and so forth, you're like, what? Why health in all? Why not education in whole? Why not housing in all?
That's health for all policies.
Yeah,
thank you.
So,
Matthias, you happy?
So I think the issues is that we need to also come to grip to the fact that perhaps other sectors speak a slightly different language, and perhaps they don't understand what health in all means. I mean, we really need to understand a bit more what is.
What about One Health? Are we selling One Health better? Sandra was making very good points on that. Is One Health a better way to go in, or is it still too self-centered?
For somebody who is not, and I'm an economist, the first time I heard about public health, One Health, I was like, what is One Health? I think we need to explain much more in very simple
What about planetary health, which is more fashionable these days?
Yeah,
You happy?
I mean, the point is that we need to get rid of jargons to first explain what it means.
Yes.
We can use jargons among ourselves, among the, those who already are expert on the issues, but there is a lot that for the populations, if you're talking about One Health, they don't know what One Health really means. So I think we need probably to go back again to those fundamentals about explaining and communicating in a much more down-to-earth way.
President, EUPHA President, boss, chief executive, you need to explain better all these concepts because the policymakers don't understand you. Which gives me a great lead to ask you to continue and save all the time I didn't save in the first round. So we finish on time, Iveta. Next
No,
round.
we absolutely did not finish on time, but I think this is such a worthwhile discussion, you know, and I think it's because this is not meant to be the meeting according to the script, you know. It's really very interactive, it's really very creative, it's really brainstorming. So we are talking about what we experience, and my heart was just bumping very positively when Agnès was, for example, talking about behavioral and cultural insights, because I mentioned that also in the beginning, that it is also at the core of innovation. So, and other things, the communication, I think this is very, very relevant, what we are talking here. So we had the first round when we identified things. We tried to answer the question whether public health is relevant, and if yes, for what reason. But we have exceptional leaders here. We have exceptional panelists. We have exceptional people who achieved a lot in their life, and therefore we would like to be them, kind of like motivational speakers, and we would like to ask you and to tell us what you are proud of most, you know, in your career. So the second round of questions was supposed to be about the best practices in public health leadership, implementing public health principles and strategies in policy and decision making. So perhaps I will start with Hans, because I know a little bit Hans, and I know how he achieved his position, that he was communicating a lot with the member states. But I think that your role did not finish, Hans. And my question for you is how to bring the health at the core of national political debates. Can you give us some guidance on that?
Thank you, Iveta. It is really the very big question. It's a very tough nut to crack. Recently, I was with the Prime Minister of my own country, Prime Minister De Croo also. And again, Belgium EU presidency is doing an awesome job, aiming to put health high at the next also European Commission. But he was also telling, I mean, what we know, that this is very tough times. There is a lot of funds going to defense their elections in many countries. I see it. I'm sitting in this room here where I do video conference, and I was talking every day to presidents and prime ministers during the COVID-19. Now they're still happy to talk to me on the condition that I don't talk about health, they say, because they say, you guys got all the money, you know, no, we have so many other hot potatoes to deal with. So we have to be a little bit smart. But let me give a good example. As some of you may know, 3 years ago, I jumped, when the COVID-19 started, to form an independent commission to rethink policies in the light of the pandemic, the Monti Commission, chaired by Prime Minister Mario Monti. And I remember very well, the first time I called Professor Monti, Sunday afternoon, he picked up the phone, and when I explained him, he told, Dr. Kluge, you're very kind, and I feel very flattered that you propose this, but I'm sure you dialed the wrong number. I have no clue about health, he told, and public health. I say, well, Professor, that's exactly why I need you, because I felt that, and Josep and me were working closely together during the economic crisis, we got only so far to engage the ministers of finance during 2009, 2010. And I thought, let's be a little bit more smarter now. And one of the innovations of the Monti Commission was that it had more non-health commissioners than health commissioners, like Professor Monti or Jim O'Neill from the UK. And then we had Sylvie Goulard from France, I mean, for Deputy Governor of the National Bank. And this was very helpful. And one of the very concrete outputs was that, with the support also of Mario Draghi that time, who was the president of the G20, was the establishment of the Joint Health and Finance Task Force under the G20, which now is institutionalized, that there is a platform for health and finance to talk together, which then led into the whole concept of the economy of well-being, which now the former Prime Minister of Iceland is taking forward, who has put her candidacy to be the next president of Iceland. And we have a coalition of central banks and finance sector to take forward mental health, because we know that 1 out of 6 of our very young people report that they feel lonely the whole time or most of the time, they have depression and anxiety. So my point is, what we need often is a crisis. A crisis helps, number one. Number two, data. And number three, public trust. Thank you.
Thank you very much, Hans. And actually, is this also your recommendation for the countries, how the countries can get health high on the agenda? Because we heard it already from Sandra, this cross-sectoral collaboration. You know, is this what we should do more?
Actually, what I learned, EUPHA, is the one size does not fit all. We have, like in Greece, for example, in Greece, it started with the economic crisis. The European Commission in 2011 or something established a task force under the famous Horst Reichenbach, at that time to overlook. And we were asked with Greece to work to establish for the first time in history primary healthcare with the famous minister Adonis Georgiadis, who is Minister of Health again. And this led, on one hand, 2 million people, or Greek people, were lifted out of, no health service. And we were commended by Horst Reichenbach of being the example of efficiency by community care, by centralizing, this and finishing this duplication of medical tests. So it's country by country, but definitely, and I think you mentioned it, or Joseph mentioned at the beginning, national health security, I believe, can help us to talk still and get the attention of presidents and prime ministers, to keep public health high, because there is an anxiety on chemical, biological, radiological events. So I think we need to be a little bit smart, and national health security definitely is still a big attracts attention.
That's very important. Yeah, yeah. Thank you very much. Thank you. That's very important. Exactly. Very insightful. Joseph, would you like to comment on that?
Many questions, but we
have not so much time.
I like Hans maybe in the last round to tell us a bit more of your little notes about you've been particularly successful to get health with prime ministers and at the center of that. We'd like to hear more about that and how can enthuse our public health profession. Of course, they are not all regional directors, but how can they get to policymakers and put health so much at the core? You gave us many of the tips already, but we'd like to hear more about the more hidden ones. Thank you.
Yeah, but Hans already mentioned that he was listening to people, right? He was listening to the nations and to what were their priorities. Anyway, thank you very much, Hans. And because we need to a little bit move forward, I would like to ask now Agnès, because you told us a little bit about the COVID-19, but I know that you have also some examples from being a former Minister of Health of France, where you are really proud at what you achieved. So can you share this with us, please?
Thank you very much for giving me the opportunity. I trust in science, and public health is science. So I always looked at what was working everywhere in Europe and tried to implement it in my country. So maybe two examples. One is the tobacco legislation. I increased by 30% the price of tobacco in 1 year when I arrived as a Minister of Health. And that was really successful, more than any other policy. And we know that it works. But the problem is that it's not in the hand of ministers of health and not even the DG Sante. It's a tax issue. So that's the problem.
I heard a country that I know that the Minister of Finance said, we want to do that. We don't want health to do that. We want to use these monies ourselves. Did you face that problem in France?
No, because we created a special fund just to put the money of the tax in a special fund, just to say to the population, this tax is not to increase the budget of the country. The tax goes to a fund dedicated to fund research on public health.
Cool.
So that was really the idea. Second example I'm really proud of, I made 11 vaccines mandatory for the children. As soon as I arrived, it was a huge fight. The French population was completely reluctant to vaccine, and the coverage was decreasing very quickly. And what I realized that the only vaccine that people trust in was the vaccine which was already mandatory, which was polio. And so I realized that when you take the accountability as the Minister of Health to make something mandatory, then you show to the people that it's safe because you are accountable. You take the risk. And so I decided to make them mandatory. It was a fight at the parliament, but now the number of measles, meningitis, everything is decreasing so quickly. So all the children in France received the 11 vaccines since 2018.
A difficult discussion. How did you manage that?
crazy.
You know,
To
because
be
what about
honest,
the anti-vaxxers and so
it was
on?
incredible, to be honest, and I would like to listen maybe to the parliamentary in the panel about that. But if I was not a physician, if I was not an immunologist specialized on immunology and vaccines, I don't know how I could have won this battle at the parliament.
Yeah, so you convince them with arguments
With
regarding the evidence, with data. Very
science.
important, very
Yeah.
important.
There you are. Data and evidence
Yes.
science works.
I like it, yes. But maybe it gives us a very good basis for the question for Sarah. And again, Sarah, for you, a similar question. How to bring health into other sectors in the European Parliament? Again, best practices, examples, strategies. What can be done?
Yeah, one of the main tools that I used was the conversion of health into money, because money speaks a lot and very high when we are talking about the EU. And I usually use this meta-analysis that checks on the return of long-term public health interventions. And for each euro invested, we can get 14 euro in return. So this is something I used in many of my negotiations, and we managed to include a better prevention part on European EU for Health program, the program for health in the EU, but also on several other files such as serious cross-border health threats. We did manage to touch or at least include planetary health, but it was deemed too much when we were negotiating. Just to give you an example, that sometimes different terms that we are using are still not out there. One Health was the one that truly passed along, and at the end of the mandate, we were already trying to have further collaboration among the EU agencies that deal on those three vertices. Another part, and I would like to touch upon something that Hans already has touched, which is data and good data and trust. And for that, we managed to create the European Health Data Space this mandate. I'm not sure what would be how would be this space if another parliament would have done it, and especially a parliament that would be more conservative. But I see Sandra there in the room. She followed the negotiations. Was as we say in Portuguese, was a tough birth, but we managed to have a comprehensive space that member states, Parliament and Commission agree on, that can be a reality, and that this will revolutionize the way that we look into health and how we look into the different aspects of health at the different policies. Because when we are discussing economic policies, housing, transports, education, culture, all of these are health policies when we reflect that these are determinants of health. And I would just like to touch upon another example that unfortunately is a negative example that happened this mandate in the European Parliament, which was that the Parliament very much lobbied against a certain industry. We took a step back when it comes to one of the biggest risk factors for non-communicable diseases and also cancer. And we, in our report for non-communicable diseases, we state that there is harmful alcohol consumption. Now introducing this benchmark, kind of giving the idea that there's a safe limit for alcohol consumption when it comes to cancer. But we know the evidence is clear as water. There's none. And this was a huge step back that we got, and I'm quite, I mean, we need to be stronger in the next parliament. Unfortunately, I won't be there because I'm not running again, but I urge everyone that works health policy in the EU to keep advancing and keep working very much together with the next members of the European Parliament to make health a reality in the different policies that we do.
EUPHA, may I add a question very quickly to both Sarah and Sandra later, and to a large extent also to Hans? Agnès was telling us about the vaccination calendar and her undoubted successes in France. Why? It's so difficult to have at least EU, if not Hans, an European calendar. Well, I know why. But why? It's a no-brainer. Surely we're all very similar in biological terms in Europe. Shouldn't we have a... Why values should play such an... But it's a typical question, naive question, I know. But why values play such an important role? Cognitive biases, I guess, as Agnès was saying, play such a big role in having a EU calendar, Sandra. It's no rocket science. I suppose doesn't have an answer really, but I still wanted to say.
Maybe Hans will give us an answer also later a little bit. Or no, Sarah, sorry.
Yeah, I can just say from my own personal experience as a public health medical doctor that, for instance, now we have the tuberculosis vaccine in Portugal only for risk populations, and those are mostly at the north of the country, not at the south. And I guess that's the same way that it goes for other communicable diseases. You know, in the Nordics, in Sweden, you have the tick-borne vaccine for the tick disease, and we don't have that in Portugal. So there's still a lot of differentiation.
This is marginal, no? With the main vaccines. This is a slightly marginal examples that do not justify the main vaccine calendar, no? The differences in the main vaccine calendar.
I mean, I understand, but communicable diseases are still very much different on prevalence among member states. But another part is that goes also for provision of health, which is a sole 100% member states competence.
Indeed, I know that.
COVID vaccine, it wasn't the EU that was telling us the calendar, it was Portugal that was telling us the calendar.
I think there is still a long way to go, and we have to discuss or also deal with miscommunication, discommunication, and so on. But it's very interesting how our panelists are complementary, and probably we invited them in such a manner. So, Sarah, you raised a lot of very interesting issues. One was the data, which was complementary to Agnès, but another thing was the economy. And is the money really so powerful? So, basically, with this, I would like to thank you, and I would like to ask you, Francesca, is there improved evidence and policy and political use of economic evidence for public health promotion and prevention? Do we can really make case for investment in health?
Well, obviously the answer is yes. So
but how? That's what is triggering us.
The bread and butter of a lot of the work that we do at OECD, although it's a little bit more complex because even despite all of the evidence, do we see change into decision making and into policies? Well, that's more of a debatable question. So the economic case is there. We make it quite clear. Actually, I should remind that about 20 years ago, we didn't have any OECD work on health. And when it started, there were some skepticism. Why do we need, in an economic organization, to look at health? And I think, you know, we work quite a lot precisely to, on the one hand, push for the case of health as a driver of inclusive growth, not just as a driver of cost, even if we have been very clear in saying that if you spend a lot on services which are duplicative, you will not improve the health of populations, whereas we spend only 3% of total health expenditure on public health. It went up during pandemic because of the vaccine COVID, but now it's going down. And in a number of countries, it's below pre-pandemic level now. So we have been, working on some standards like system of health accounts to keep on proving, hey, we still invest too little in public health, despite the facts, and we have shown in our work, in our modeling, that the returns on investments are incredibly high. But I think it doesn't stop there with having those, investment cases, as I said, the return on investments, the importance of public health interventions for broader economy, so GDP growth, but also labor market productivity of individuals. All of this we do in our work in other modeling. But we're trying to push also for improved dialogue between health and finance. And it's very hard going because despite the fact when we have had a network now of senior budget officials and health officials now for several years at the OECD, but they still speak different language. And the finance officials, for them, is still controlling cost. So we're pushing, for example, things like, can we have even decision-making which span over multiple years, because very often budgeting practices are more bound to look at what happened in this fiscal year. And we're talking about public health. You need investments which will span, over a long time and will deliver returns, actually not immediately, but farther ahead of time, although you can have obviously some very, very immediate returns as well. So it's that issues of changing perhaps the narrative, but also the mentality that if we're talking about public health, we are talking about returns, investments, and so forth, you need to lengthen the horizon at which you make decisions. You cannot just make your decisions on what happened on a year by year, because that's what you do. Well, you cut on public health because that's the easiest thing to do. And so those are the sorts of issues that we're trying to see, that dialogue, changing the perspective, changing the time frame, looking at the inclusive growth the health can deliver, while still highlighting that there are things that we need to do. We cannot just say, well, we just need to put more money and more money and more money. We also need to be able to reduce the waste in health system, right. We've said several times, and so forth. But so that's our contribution. We'll keep on working on that.
Yes. Well, actually, this brings me to Sandra and the final round of the inputs. Sandra, how can you help each other? OECD, DG Sante, you have great examples with DG Trade, so I think you are really a perfect person to close this discussion.
Not sure if I'm the perfect one, because, I must say I was very sympathetic to your plight on the pushing of the vaccines policy, because, this is exactly where we need public health people to go out and speak, because a minister is always a minister, a director general is always a director general. You need some third-party endorsement, which is very important, and it's really quite vital that you help us. I also find that what Francesca was saying resonates deeply with me because this dichotomy of the numbers and the budget. So I will tell you what my situation is. We had, thanks to members of parliament like Sara Cerdas and others, this fantastic boon of an EU for Health budget that was huge. It was cut by 52% because they decided this would go directly to HERA for preparedness. So already there was a choice that was very political, and we found ourselves with less than half of the money. Then, let me say to you, this budget had no real continuity in the future. So in many respects, I am trying to go for sustainable financing in the sense that I know that what I am trying to finance will have a future. I'm not sure about other DGs, but in the case of DG Sante, we're trying to make choices where, the sustainability is guaranteed, not because I will have a constant source of money, but because we have put the right seed in the member state. Now, as I said, we had to live from crumbs in the past, meaning that we had to push a bit of health policy in the cohesion funds. We had to push a bit of health in the fund that was perhaps going for peripheral regions or ultra-peripheral. So we were trying to do, and this, may I say to you, for us, it was a major game changer to have our own budget. And why? And here comes the real problem that I see where I need the help of public health. So we you were saying, what are you most proud of? Well, I must say there have been many successes. I owe it to the president, I owe it to the commissioner that, you know, went out and defended certain things. But let me say, one thing that I really am proud of is that I actually explained to every individual colleague that had a policy that would have a bearing on health that they were affecting health. It's not that I wanted to have health in their remit. It's that they were affecting me. And this has been extremely effective because, you know, I mobilized understanding, for instance, from transport policy, when we had to deal with the movements of people, you know, coming from China or not coming from China. You had to have the MOVE people understand why it was their policy having a bearing on me. And then it becomes totally symbiotic if you work very well. But every single policy, and by the way, I'm also Director General for Food Safety, so you should never forget that there is also this agricultural part. And it's extremely important that these colleagues realize that if we want to have equity, or rather to have fewer inequities, we need to have every policy working towards a certain objective. And the objective, I repeat, of community, a community that is healthy, is a very long objective. So my third plight in budget numbers is that I will not be reaping results by the end of this mandate with the EU for Health budget. It will be much longer. But, you know, we are very good at response in health, but the prevention part needs to be, and this is long-term. Prevention is not that you're healthy at 90 because, you know, you're doing the right things at 90, but it comes from your childhood, your adolescence, and so on and so forth. When I see today certain numbers where we are not doing, or we are not having the population really alert on prevention, I'm really scared. So, on costs, we can reduce costs if we reduce the patients, meaning that, you know, sometimes you can also avoid even high blood pressure by having a healthy way of life. I don't use these lifestyles because I was stigmatized, but you know, there is an issue with the way we are not reducing the number of patients up front, which is an economic judgment also, but it's also a moral judgment. You should not leave those who are, I would say, in an inequitable situation, in a poor situation of health, because that is the outcome, the guys who have. So I wrote down many bits and pieces. I remember that the lockdown cost trillions, and you were mentioning the famous 3% that exploded to 6% at the point, but it was just because of the vaccines, so there was not a real long-term vision. In fact, we have retrenched those budgets in such a way that it has gone below 3%. For a software that is so important in a community, I feel it's really an indictment of the political choices. A bit of a reply to, I would say, the vaccines calendar, even though it's a very it's a minefield and it's a very difficult territory, but I'm never shirking these things. Let me say to you, a vaccine is still a vaccine. I may be very fond of vaccines, but the vaccine is still a vaccine. So you need to have a government that really feels comfortable in facing the moments when the vaccine goes wrong. Let me say it very bluntly. So some countries have created a very good fund, collective fund, pour dédommager those who may encounter problems. So we are not different. Definitely, we all need, I would say, more or less the same vaccines. But the way you can shoulder the burden once the vaccine goes wrong is different from member state to member state, apart from the fact that we do not have competence, but plenty of advice comes from ECDC. There is a total full table of the vaccines you would need, not just in a static fashion, but even if you were to be exposed to trips and also ECDC is giving you plenty of advice, which is definitely not binding. But be always very much aware that health comes with a price tag, always comes with money. And this is where I insist, if I had more support from the public health experts, that you are with the data about how much we would somehow safe, if we could have better prevention, how many beds would be freed in hospitals because we would not have the cancer patient at the end there. Of course, all in the freedom of people, but definitely freedom then implies that you will need to face a certain problem with your health, and you cannot make the community responsible for that.
Amazing. Thank
but
you.
I saw that you wanted to have the floor.
No, we have only 5 minutes till the end.
Just to let you know, which was amazing for me, when I made all these vaccines mandatory, all the medical societies were with me except one, the Public Health Association. Yeah, because they didn't like the idea of mandatory. Exactly.
Very important. Thank you very much, ladies and gentlemen. I think it was very, very, very important. Thank you very much for your honesty. And I would like to still give a floor to Charlotte, to our Executive Director of the EUPHA, to come back with the ideas, observations from the audience, from you, from people who were at home. And I'm sure you have a lot of things to share with us.
Lots of things online. I don't know if we have time for people in the audience, but we have a moment to have a reception. We'll see. Moderators will say on the audience what is coming is, yes, it's really good, public health is good, but there is no love without proof of love, and public health professionals are not well paid, and lots of questions that they say they need salary, they need WHO to push public health, and not only hospital, they need EU to push for education and public health, and we need more courage in that. So how do we spend in public health? Lots of questions going on that. How do we face the struggle between the public health approach versus a medical approach, so both for WHO and the Commission. Some questions, of course, again, on equity. How did it work for the vaccine for the more marginalized population? Does a national law goes to the most deprived people? And a direct question to Sandra also, why the EU Commission did not publish the revised taxation for tobacco directive. And yeah, I think I kind of went through all of it. So as I was quick, maybe we can take 2 questions of the audience and then have the final wrap up.
Yes, we thought as well, if the audience has the drinks afterwards, I'm sure without alcohol, maybe we can continue the debate a bit longer if some of the panelists are prepared to take another 5 minutes to talk to the audience in more detail, as you came here all the way. But let's have a couple of points now, a wrap up, and then perhaps a few more minutes with people in the audience, if you're still willing to stay here a bit longer. Please.
Thank you so much, JJB. First of all, thank you to everyone, to Sarah, Dr. Kluge, and all the speakers. So my name is Florence Bertoletti, and today my question is related to the commercial determinants of health. I'm a commercial determinants of health expert. I think there's one thing that has not been acknowledged, and that is that Sarah talked about it more than anyone, and that is that the arguments are also strongly put at EU level, who is a market, by the big lobbies, the health-harming industries. And a lot have been said about data, and we have the data, we've got the best buys. So we need more, but we already have a case for a return on investment in health. Most of the arguments are blocked, absolutely blocked, because of the better regulation agenda. And actually, when the impact assessment of legislations are made at EU level. And this is where we need NGOs and the public health community to be able to articulate these investments, these documents that we already have at that level. And that is something that we need support for and financing for, so that we can make the case.
Thank you so much. It was very inspiring. My name is Federica Castellana, and I am at the end of my public health master. So these are all things that I've been studying for the past 2 years. So it's quite interesting then to see the reality and the practice. My question is related to what all of you just said about the importance of knowledge transfer and communication and how we are actually able to communicate and to talk with different professionals and actually to have the multi-sectoral approach. But then when we had the first question, I just noticed that knowledge transfer and communication was only the 30% of importance. So you said it is so important in everything. So how can we do for making this a priority for all of us and also the people in the audience? So this is my question. How can we transform this as a priority for all of us? And thank you so much.
Music to the observatory ears, I can tell you that.
As well.
Let's go to one last round.
One last thing, there were lots of things also on the audience about the now what and asking about the young generation. So on Friday, EUPHA Next will lead with the people, Monica, coordinator here, and Friday we meet again. So we can wrap up the week and see what is next. So it's not finishing now, it's beginning.
Thank you very much. Maybe, Iveta, we have one final round, 30 seconds each.
30
we'll start with Hans.
I
know you have a tight schedule now, Hans, like all of you. I know panelists, you're very busy. Do you know, it's interesting, Iveta, that we said that last round was the panelists asking to the public health profession, but the public health profession is asking to the panelists, saying, where's the money? Where's the boldness? Where's the support? So there is some challenge to you, colleagues, and I know you could defend your case very powerfully, starting with WHO about the way you're helping that community. But let's hear you. Let's start with Hans, and then I'll continue online with Sarah, and then into the room. Hans.
You mean like a final statement,
Please, exactly.
One sentence, please.
The final sentences to get us home in a good mood and positive, as you always do that very well, Hans.
It's difficult to beat you there, my brother. But okay, you know, trust has been mentioned a number of times. So we need really all of you, the public health, let's say, force, to regain the trust. And I think three things here. To improve on the communication. Number two, to make mandates in the future limited and transparent. And third, to demonstrate the progress on health to issues that really matter to the people, to the communities. Thank you.
That's
amazing.
Absolutely perfect. Thank you very much.
That's so clear. Thank you, Hans.
Great. Sarah, your last famous words, until we meet again very soon, as we do very often in these platforms.
Yeah, very soon. I would just follow up on what Hans just stated and say that starting on the 16th of July, you're going to have a very different European Parliament, 720 members. So they are there to represent you, not only the public health community, but also 455 million citizens. And for that, don't be afraid to reach them. They are there to represent you. So don't be afraid to reach them. Make it reach the communication that you have, the best evidences that you have, and please push them to legislate better for health. It's not only when we are dealing with the program for health, it also has to do with transports, with tourism, with fisheries, agriculture, and there's so much more that we can do. So use the parliament wisely. They are there to hear you. So make sure to bridge the gap between the policymakers and best evidence-based policies.
Yeah. Amazing, Sarah. I think it clearly shows, as we discussed, that health is a political choice. So thank you very much for this plea and for this urgency.
But Sarah, may I add is not only don't be afraid, but you must contact you and them. And secondly, may I add, Sarah, and go to vote, please. Vote for the European elections, please. Thank you very much, Sarah. Francesca, I'll start from my left without any hierarchical order. Your famous last-minute words. Last 30-second words.
Okay,
lots of hearts and applause.
First of all, I think it came out in one of the comments. Yes, public health is not attractive enough, and that has to do also with pay, and that must be addressed. It cannot be that it remains the poor cousin if we want that to be more relevant. So that's fundamental. Data was mentioned a lot, and we love it in OECD, obviously, data. At the same time, it should not become an academic exercise. That's unless, we have the best possible data and the best possible model and so forth, decision is not made. Sometimes decision must be made with imperfect and moving evidence as well. And that's something that we need to keep ourselves in the public health community and more broadly. And the point of communication, I think I mentioned at the very beginning, I think we need to get rid of all the jargon and go back to the community, as as was mentioned by Sandra, because in the community, when you're dealing with issues of public health, of poverty, and so forth, we need to speak a language that everybody can understand. And I think we just need to get to that more common ground language that unites all of us when we're dealing with people. Yeah.
Thank you. Thank you very much. Sandra, you're provocative,
no.
But like Hans, you're an optimist and
I am
very energetic, and you guys. Well, you wouldn't be doing that job if you're not optimistic and energetic.
No,
because
I can tell you.
It's a difficult
you could
job.
have a taste this morning.
So set us going like Hans with some messages forward.
So just a simple message. Stay the course, those who have opted into public health, because I do believe that public health has a major, I would say, attraction for all other disciplines. So you need to get a bit more pollutable and polluted with the other disciplines, meaning that if you have public health, I would put next to it another discipline so that you can speak also the other language. But you definitely need to stay the course because it's a fascinating discipline. On the other hand, be a bit more, I would say, supportive when it comes to defending, I would say, elements that we have had in policies which can only be defended as a community action. I know it's a big ask because there is a necessity for individuals to feel that they can make any and every choice that they want. But I think that a bit of wisdom from the public health community for all matters concerning prevention and the way you lead your life would be appreciated on this side of the trenches.
Absolutely.
Thank you, Sandra.
Thank
much
you very
appreciated.
Much.
Thank you.
Do you feel more positive, Agnès, after today?
I have two things to say. The first one is I think we should develop now collectively the concept, which is very well known in medical activity, which is the concept of evidence-based medicine. We should translate that in evidence-based policies. Evidence-based medicine is science, the experience of the medical doctor, and the will of the patient. It's a triptych. Evidence-based policy, it's science, it's the politics who take decisions, and it's the will of the society. And it's also a triptych. This should be really the way we think if we want to implement public health science in politics. Evidence-based politics, like evidence-based medicine, a triptych. The second thing is much more provocative. I think that prevention and working on determinants of health should not be the problem of the health ministers of the DG Center.
Yeah.
I think your lobbying, your advocacy should be, we are convinced, should be in all of the ministries, all of the policies, because we have no capacity to act on transportation, on food, on anything. So you should not address the ministers of health. You should address all the others.
Yeah,
Thank you.
amazing. Yeah.
Thank you. And before I give the last word to EUPHA as our host today from the Observatory, thank you very much indeed. And yes, in the Observatory we say we work on evidence, we transfer evidence with knowledge brokering. We say evidence-informed decision-making. Because we acknowledge the limitations of evidence and the importance of the political economy, of decision-making, and the respect to the policymakers, which we need to understand better if we want that evidence to get into the policy. EUPHA.
I don't have any special words prepared, so I will be very spontaneous. I'm so proud at this panel and at this meeting because I think it was amazing, and I'm really grateful to our speakers for sharing their knowledge. I learned a lot, and I'm really looking forward very much to communicate also in the future with you, all of you, and to collaborate to improve the public health and make public health and health relevant again in the agenda. And I really cannot be more happy because we heard about quintuple helix, about cross-disciplinary collaborations, about communication, about innovation, about many things, and I'm happy to continue the debates also after this. So thank you very much to the Observatory, and thank you very much once again to panel and to all of you for creating this wonderful event, and to Charlotte, our Executive Director.